So we have Dr. Mandagini Meg, and Madam is the chairperson of ICOG Foxy. And Madam was quite supportive, and she was advising on each and every aspects of scientific program of this 2 days conference. And Madam is the official advisor to the Officer on Special Duty Family Welfare, Government of Maharashtra Health Department, and she has received plenty of awards, and she was the past chairperson of AMOX. And we have Dr. Sudha Prasad. Madam is the Director, Professor and IVF Coordinator and IVF Reproductive Biology Center, Department of Obstetrics and Gynecology, Maulana Azad College. And Madam is currently the President of Indian Fertility Society, which is doing enormous work in the academics in reproductive health, reproductive medicine. And we have Dr. Gauri Devi Ma'am. Madam is the immediate past President of the Society and a senior consultant in reproductive medicine in New Delhi at Ridge. Madam has plenty of awards and presentations and papers to her credit. So I hand over the session to all the three chairpersons to take the oration thing further ahead. Over to the chairpersons. Sumit, please share the slides.
So, very good afternoon to everyone. I am really privileged and honored to chair this very, very prestigious session of NOESIS Oration 2020. Thank you, Doctor, for that very, very kind introduction. And I also welcome all the delegates, my co-chairperson, Dr. Sudha Prasad, Dr. Gauri Gupta. And so this NOESIS Oration has been conferred on Professor William Ledger. And I have a really pleasure and also a privilege to Professor William Ledger. Professor William Ledger is a head of discipline and professor of OBGYN, School of Women's and Children Health University of New South Wales, Sydney, Australia. Very prestigious post he is holding of Director of Reproductive Medicine, Royal Hospital of Women, Australia. Also, he is on a very special post of a senior fertility specialist, and he was a president of 13th Biennial Congress of IVF in Australia of the Pacific Societies for Reproductive Medicine. Also, he has got, and he is going to deliver a very, very important topic in the reproductive medicine. That is he is going to talk on he's giving his oration on the optimal luteal support during this NOESIS conference on 8th of August. And we are bestowing this oration, and we acknowledge his continued support in the contribution of the field of obstetrics and gynecology. Also, we wish him all the best, and we will like to hear Professor William Ledger to deliver his oration. Sir, please, Professor. Can you share the screen now? Hello?
Hello, Madam Gauri Ma'am.
Yeah.
Tell the oration.
Yeah.
Good afternoon to all the persons, Dr. William Ledger and Punjabudi and all other delegates who are attending this. First of all, I would like to congratulate Kunjumadi for arranging such a nice virtual congress, a very successful one. Now, the previous slide, please. The previous one. Now, it's my proud privilege to read out the NOESIS oration scroll for Professor William Ledger. This is organized by the Telangana Obstetrics and Gynae Society, which is affiliated to the Federation of Obs and Gynae of India. And this oration 2020 has been conferred on Professor William Ledger, who is the head of the discipline of Obstetrics and Gynecology, Faculty of Medicine, School of Women and Children Health, Sydney, Australia, for the topic Optimal Luteal Support during NOESIS 2020, held on 8th of August on virtual reality platform. Now, by bestowing this oration on him, we acknowledge not only his continued contribution to the field of Obs and Gynae, but also for being a beacon of light for members of varied generations to explore, comprehend, and dedicate the discoveries for overall patient care. wishing him many more years of academic excellence. Dated on the 8th of August 2020, signed by Dr. K.U. Kunjumuddin, who is the chairperson of Perindalmana Ops and Gynae Society, and also by the secretary of the society, Dr. Abdul Wahab. Now I request, there is a certificate attached. Next, please. And this certificate shows the School of Women and Children Oration 2020 certificate, which is conferred on Professor William Ledger. Now, I hand over the mic to William Ledger. By bestowing this oration on him, we acknowledge to give his oration on optimal luteal support. Comprehend and dedicate the discoveries for overall patient care. Wishing him.
Well, thank you very much for that kind introduction. I hope you can all hear me, and it's a great pleasure and privilege to be sitting in my study here in Sydney, Australia, talking to my friends and colleagues across India. Modern telecommunications are truly a wonderful thing. I'm trying now to share my screen, which seems to be looking good. Let's just see how we go here. And that should be working well. Now, I'm sure someone will tell me if this is not working, so hopefully we can go on with my lecture. So thank you to the Society. It's lovely to see my friends and colleagues on the side of the screen here. Dr. Kunjumuddin and I go back to the days in Vellore in India, and it's lovely to see you all. So my topic for this evening is to talk about luteal phase support in ART. My affiliations have been mentioned. I'm a professor who does a lot of clinical work. I strongly believe that those of us who teach should also practice. And so this talk is based on evidence, but also my own experience of running quite a lot of IVF cycles, which is something I truly enjoy. So it's nice at the beginning of a talk to go back to the beginning. And Louise Brown, who you see here as a baby, and you see here as a teenager, was born on the 25th of July, 1978. So she just had her 42nd birthday. So the whole subject of IVF has been alive for 42 years. And so many great changes have happened in that time. I'm sure all of us who practice in the specialty have had great reward from the constant innovation, the washing of science against clinical practice, and being able to help more and more women and men start their family and to overcome the problems of infertility. I direct your attention briefly, to the pictures on the left-hand side of the screen. This is the hospital in Oldham in Lancashire, Dr. Kershaw's hospital, which is a small cottage hospital in a small town in the north of England, where Patrick Steptoe, this gentleman, undertook laparoscopy to collect the egg from Louise Brown's mom. That was the operating theatre in which he practiced. And I'm sure you'll all agree that things have moved on a long way since those early days. Patrick Steptoe and the embryologist and the father of our specialty, Professor Bob Edwards, seen here and here, were both knighted for their contribution to the world of IVF. And of course, Robert Edwards subsequently was awarded the Nobel Prize for his contribution to our specialty, the highest award that anyone can be given. And it was a great day when Bob Edwards was finally given that accolade. Things have moved a long way, and this is not a lecture in history of IVF, although I do find it fascinating, but I thought you'd be interested to see the trends in our own group. IVF Australia is the largest IVF practice in Australia. We run over 15,000 cycles a year in this country, and we have clinics around the world. And we're seeing different trends in treatment looking over the last decade. So, for example, the days of the long down regulation protocol are being replaced with GnRH antagonist cycles in over 70%. We've seen an upsurge in the amount of ICSI which is being used from about 50% 14 years ago. Now we're at 65%, but that is now coming down. We're doing less ICSI this year than we did last year, and I think that's a trend which will continue. One thing which we're doing more of and is pertinent to this evening's talk is we're doing many more freeze-all cycles with no fresh embryo transfer, using the antagonist cycle and then a GnRH agonist trigger to prevent moderate or severe ovarian hyperstimulation. And this is a strategy which is very popular now in our practice because, as I'll show you, the pregnancy rates from frozen embryo transfer are at least equivalent to fresh. Whereas in the past, having a frozen transfer was not so likely to give a pregnancy. That problem has been overcome by technology. The other thing which has really taken over in Australia is single embryo transfer on day 5 or occasionally day 6 with a blastocyst. And that means that our multiple pregnancy rate from IVF in Australia is less than 5%, something which I think in 21st century is something we could be proud of. And the other thing which I'm sure you're seeing in your own practices is that the women who access our surgery are getting older and older and older. The mean age across the whole of the IVF Australia practice is 37. My mean age in my own practice now is nearly 40 years of age. So almost half the patients that come for IVF are over 40. And I'd be very grateful if any of the audience tonight have a clever solution to how to help older women have a better pregnancy rate. Please send me an email or a text message. I would embrace you very seriously, because I don't think we yet have a solution to how to treat the older patients particularly well. This is a paper that I published with our head of epidemiological medicine, Dr. Georgina Chambers, now Professor Chambers, in 2016. And it looks at data across the whole of the Australia-New Zealand database, looking at the pregnancy rate for all patients having fresh embryo transfer compared with frozen embryo transfer. This ends at 2013, because 2013 was the year in which in Australia, the chance of pregnancy and live birth, which was pretty consistent over the decade for fresh transfer, with frozen transfer became equivalent. And you see the steady impact of vitrification and improved technology on the live birth rate after frozen transfer. And since 2013, we've achieved at least equivalent pregnancies from frozen versus fresh transfer. So if we're talking about luteal support, it's no longer just a matter of talking about luteal support for fresh transfer. We need to work out the best strategy to provide a cycle of treatment for a woman having a frozen embryo transfer to at least maintain, if not improve, these quite impressive numbers after transfer of a cryopreserved blastocyst. The results after fresh versus frozen embryo transfer have now been meta-analyzed by Peter Humayden's group in the Netherlands, and this was published last year. The reason being that there have been some impressively large and impressively good quality randomized trials from China and Vietnam comparing fresh and freeze-all frozen transfer. And that's another new innovation in the world of IVF, because in years gone by, the quality of reproductive science coming from the Asian countries such as China, Vietnam, and India has been lower than that coming from Europe and the US. And something that pleases me greatly is that those days are behind us. And we're seeing some very strong signs, not only the comparative randomized trials in clinical practice, but also laboratory science from our region, as well as centers in Europe and the US. And if you go look at, these are the highest quality trials in the world, comparing fresh and freeze-all, coming now from Asia, not just from Europe and the US. And I hope that's a trend that will continue, and I hope it's something that many of us can contribute to. So what the meta-analysis showed was absolute equivalence of fresh embryo transfer versus frozen embryo transfer from a freeze-all strategy. And with a subgroup analysis, perhaps not surprising, the polycystic ovary women who produced a large number of eggs did better after freeze-all, probably because the endometrium in these very high responder patients was not good quality for fresh transfer. But with a normal responder patient, there was no difference in live birth rate, very tight relative risk between fresh and freeze-all frozen transfer. And that is consistent across all the trials as well. There are very few outliers, which says to me that we have a choice with our patients now. We don't have to offer freeze-all to everybody. That would be too one-dimensional, but it's really rewarding to be able to speak with our patients and say to them there are pros and cons of fresh or frozen, and to individualize their treatment. Because I just remind you of this old paper now, 2011, from, again, a father of our field, Professor Paul de Vroy and his colleagues, talking about avoidance of OHSS using the agonist trigger in the antagonist cycle and segmenting, by which he means freezing the embryos and do the transfer later to avoid the chance of an early or late OHSS. And again, in our own practice, we use this a lot. And I have not had a patient in hospital with OHSS now for 8 years by using this approach in a selective way. So let's turn more to the topic of this evening's talk, which is about luteal phase supplementation in ART. And when I was putting this together, I thought these were the questions that are relevant about what is the role of luteal phase support, when is it required, how should we do it, how long should we do it for, and what about frozen embryo transfer to wind up the talk. So one of my students drew this beautiful picture of the menstrual cycle, and she's very proud that I'm showing it to you this evening. And it just reminds us of the role of the various ovarian steroids and the pituitary peptides in the regulation of the cycle, with estrogen dominance in the follicular phase leading to development of a proliferative endometrium, the LH surge leading not only to the release of the oocyte, but also to the formation of the corpus luteum, which then secretes large amounts of progesterone in the natural cycle, allowing the secretory endometrium to develop, and then allowing implantation should a good quality embryo be available in the uterus at the right time. And that beautiful cycle, regulated very carefully, rotates monthly for young and middle-aged women in reproductive terms for many years. The amount of progesterone secreted in the luteal phase is very high, and it is perpetuated for many days. Obviously, if there is HCG from a pregnancy, the progesterone level will then continue to rise. If there's not a pregnancy, it will fall to trigger the menstruation and the start of the next cycles. So just keep that very simple picture in mind as we look at what happens in ART. The role of progesterone in the luteal phase is complex. It does several things. It works at the level of the pituitary to slow the rate of LH pulses from about once every 90 minutes in the follicular phase to once every 4 to 6 hours in the luteal phase. And that's important to suppress recruitment of further follicles naturally and promote uterine quiescence, preventing uterine contractions, which could expel an embryo. And part of the role of progesterone in IVF is to mimic those effects of natural progesterone in the natural cycle. And then obviously the transformation of the endometrium from proliferative into secretory to make it receptive. And if you look at the literature, the upregulation of many secretomes of growth factors and cytokines that are promoting implantation. And then in the presence of HCG from a pregnancy, maintaining the early pregnancy by maintaining the corpus luteum secretion of progesterone right up until 9 or 10 or 11 weeks of pregnancy, at which point the luteoplacental shift occurs and placental steroids take over. Arpad Sharpo, working in Hungary back in 1978, showed that if you perform a luteectomy, if you remove the corpus luteum in early pregnancy, there is inevitable pregnancy loss, showing you the absolute necessity for luteal secretion of progesterone to maintain pregnancy. And he went on to perform luteectomy and then give back progesterone, showing that was the only agent that was necessary to allow maintenance of pregnancy up to 7 or 8 weeks when the corpus luteum becomes replaced with placental secretion. So although a very old study, not one which I think we'd regard as ethical today, I think it is critical to remember that progesterone is the only steroid that was necessary to maintain these pregnancies after removal of the corpus luteum. So why do we need to give progesterone in a stimulated cycle? And this nice review by Bart Fauser shows you the pathophysiology of secretion of ovarian steroids in the stimulated cycle. Firstly, the supraphysiological secretion of estrogen in the follicular phase has an impact on LH secretion. All that estrogen from the many, many follicles that are developing makes aberrant pituitary pulsatile release of LH and breaks down the normal negative feedback. Low LH levels in the early to mid luteal phase lead to luteolysis, failure of support of the corpus luteum, leading to failure of implantation because of failure to express all those cytokines and molecules that support the normal implantation. The luteal phase in the hyperstimulated cycle is naturally shorter than the normal cycle, with menstruation about 7 to 10 days at the most after the trigger. And this nice picture from Connell's paper in 2015 shows you the luteal phase in ART. In the blue, we see the level of HCG after the trigger. So HCG will rise to a high level and then fall away in 4 to 5 days. That HCG will stimulate secretion of progesterone from the abnormal corpora lutea from the IVF cycle. Progesterone will rise in response to the HCG from the trigger, but because the levels of HCG are going down, that progesterone secretion will not be supported. So 6 to 7, 8 days after the trigger, progesterone will fall below the healthy threshold, which is between 80 to 100 nanomoles per liter. And that fall happens before the pregnancy can secrete HCG itself. So this gap is what occurs, meaning that if we do not give luteal phase support, the chance of pregnancy is severely diminished. We can see that in meta-analysis. This is from the Cochrane review of 2011, and it shows a very clear loss of chance of pregnancy without progesterone. This is studies that gave placebo either up to the pregnancy test or further on into pregnancy. And what they showed was that placebo rather than progesterone really impaired the chances of implantation to about half. So luteal support of some kind is necessary in ART cycles. So what do we have available? Well, traditionally we use HCG, injection of HCG every 3 days after egg retrieval at a dose of 1500 IU on day 3, 6, and 9. Will maintain corpora lutea, will maintain natural secretion of progesterone and close that gap between the trigger HCG stimulation of progesterone and the early implantation. And that works well and is acceptable to women, some of whom are not keen on vaginal progesterone or intramuscular. But over the years, the luteal phase support has really become much more commonly given with progesterone, and there are a number of products on the market. Situation will change from country to country, but in Australia, we use a lot of Utrogestan, which is micronized progesterone, either 200 milligrams 3 times a day or 400 milligrams BD. We have Crinone 90 milligram day gel, which is given once or twice a day. We have endometrium tablet, which can be given twice or 3 times a day. Other formulations of vaginal preparations, and also intramuscular progesterone in oil in a dose of between 25 to 100 milligrams. So I guess the purpose of this evening's talk is to talk about how do we select between those for different categories of patients, who should be offered what. The principles are that if you give no treatment, things will not work well. Your pregnancy rate will be low. HCG has been shown to be better. Intramuscular and vaginal progesterone in most studies are better than no treatment, and they're equivalent to HCG. But the hazard with HCG is promotion of ovarian hyperstimulation syndrome in normal or high responders, and so we must be cautious not to administer HCG to those who are in danger of that condition. And more recently, and I'll show you the evidence, there have been some data showing that oral progestogens can be used for luteal phase support in certain circumstances. So this is Professor Alinani from Egypt, who produced this meta-analysis, and it's looking at a comparison between vaginal and intramuscular progesterone in terms of clinical pregnancy rate, ongoing pregnancy rate, and live birth rate. And although there are not many studies in those days, you can see equivalence between intramuscular and vaginal progesterone. Intramuscular progesterone, it seems very popular in the United States, much less so in Europe and in Australia, and we'll talk why that might be. This is George Griesinger's paper from 2018, talking about using oral progestogen, dydrogesterone, compared with intravaginal micronized progesterone gel for luteal support in a randomized trial with some very prominent authors from around the world as part of that study. And what they showed was that however you compare the chance of pregnancy, at 4 weeks, 8 weeks, 12 weeks of gestation or live birth, there was equivalence between dydrogesterone orally taken against progesterone gel. Overall live birth rates were quite respectable, and this was a big study across many centers. So although I don't think the world is ready for giving oral gestogen for everyone, if you have a case where someone is not able or wishing to use vaginal progesterone, this may be an alternative for them. IVF Worldwide is a very good website. They survey many, many clinics and just ask us about our practice, and then they formulate that data into an overall overview of what the world is doing. And again, if you're in charge of an IVF center, I encourage you to sign up to the IVF Worldwide network, and you can contribute your own data. And this analysis shows you that the most popular kind of luteal phase support around the world is vaginal progesterone. You can see whether it's a cream, a gel, a capsule, or combinations. About 65% of all the cycles of over 50,000 reports were managed with luteal phase support with progesterone, with, in this analysis, quite small numbers having HCG here and here. So progesterone is popular. The reason is this first pass effect, that if you measure serum levels of progesterone after administering it vaginally, often the levels are not very high. But that's also not very relevant, because what's been shown both in animal models, and I did some of that work years ago, and also now in human, is that there is local passage of progesterone from the upper vagina through the cervix into the lower segment of the uterus and up to the fundus. And we know this also from our work in early pregnancy, prevention of miscarriage with progesterone, that even if you do not achieve a very high concentration in serum, the local effect is clearly there. So don't worry too much if your serum levels are not so high. To talk for a moment about intramuscular progesterone, I pulled these pictures off the internet. Many, many women are showing you how painful and difficult IM progesterone is. You can see the size of the needle, the volume of the administration is quite high, and this is a suspension of progesterone in oil because it's not water soluble. Women heat the oil to try and make it more easy to administer. It's not pleasant, it's painful. It has to go deep into the gluteus maximus muscle. There have been problems of sterile abscess, and acute eosinophilic pneumonias have been reported. So in our own practice, we avoid it if we possibly can. Occasionally, a woman reading on the internet has decided it's the right progesterone for her, in which case, of course, she can have it. In Australia, she has to import it from overseas because it's not manufactured in this country. It's quite difficult to access. But personally, I'm not convinced that the evidence is there that it is superior to the more easy to use and acceptable methods of luteal phase support. Here's Mitch Walley's study from 2010, 544 women in a long protocol with luteal phase support with progesterone, randomized between intramuscular and micronized vaginal progesterone. The rate of clinical pregnancy, the rate of miscarriage was no different. This is Alanani's meta-analysis of IM versus vaginal progesterone. Again, clinical pregnancy, ongoing pregnancy, and live birth rate. And again, no difference in favor of intramuscular versus vaginal progesterone. So I think in rare cases it may be indicated, but the generality of cases that we see, probably not necessary. Bob Casper wrote in The Lancet about HCG for luteal support many, many years ago, and what he wrote still stands today, that, as I showed you, 1,500 units every 3 days is easy for the woman to give. It rescues the corpus luteum, and once you've done the 3 doses, you stop, because the early pregnancy HCG will sustain corporal luteal secretion of progesterone. So 3 injections is all. However, the pregnancy test will be positive for a few days after the last injection of HCG. Be careful of that. The level not always high, but it's detectable. And we've talked about risks of OHSS. In our own practice, we use HCG quite frequently in women who are poor responders, maybe older patients, particularly those who've had 2 or 3 transfers of embryos without a pregnancy, as an alternative to progesterone, or even in some cases, not evidence-based, but because the patients become very desperate, we might use HCG and progesterone just to do our best to sustain a pregnancy. I'm not convinced that that has much merit in science, but the patients sometimes request it. If you look at Cochrane, look at progesterone versus HCG, you'll see that overall, the pregnancy rates are identical. That is, either or can be used with equal efficacy. Use of HCG is not to be cautioned against lack of efficacy, it's lack of safety because of OHSS. The next question: in some practices, people give estrogen as well as progesterone in long down regulation cycles. This is Stratis Kolobiniakis from Athens, meta-analysis of studies, 4 studies included. Giving estrogen along with progesterone in the luteal phase did not have impact either on clinical pregnancy rate or live birth rate. Other studies have also been published, and in our own practice, we don't add estrogen tablet or in any other form, gel, cream, whatever, to progesterone for luteal phase support. It doesn't seem to be necessary in long down regulation cycle. And we have this data from Human Fatemi, looking at using estrogen along with progesterone for LPS in antagonist cycles. Here you see the data for progesterone alone. Here you see the data for progesterone plus estrogen, and no difference between the two groups, either in pregnancy rate, ongoing pregnancy rate, or miscarriage. So personally, I don't see a need for giving estrogen. I think sometimes in IVF, less is more. Simple protocols are the most effective and the most patient-friendly. And when I see someone who's using many, many medications and not pregnant, one of the tricks as the professor for the second or third opinion is to get rid of many of the meds and go back to square one and just do something simple. And sometimes you'll have success with that. The next intriguing question is, when do you stop? I have had women who started on progesterone for their IVF cycle for luteal phase support and are still using it when they come back for the 6-week check in the postnatal clinic, which seems excessive. There's been a lot of debate about how long you should carry on. The science is there saying that it's perfectly reasonable to stop progesterone at the time of a positive HCG clinical pregnancy test about 2 weeks after your transfer. There's no difference in pregnancy rate in randomized trials between stopping early, carrying on later to 6 weeks when you do the first ultrasound, or even beyond. This nice study presented at ASRM in 2008 looked at patients randomized to intramuscular progesterone for the first 6 weeks versus 11 days, a short protocol starting on the day of egg collection and finishing on the day of positive HCG. Identical and very impressive clinical pregnancy rates, identical and impressive ongoing pregnancy rates across the two groups. So scientifically, it's acceptable to tell women to stop their progesterone very early. And I guess if you have a patient who finds it very difficult to administer vaginal progesterone, or for that matter, intramuscular, that's a wise thing to do because there's no clinical need for it beyond that. But in the real world, there's a conspiracy, I think, between our patients and our doctors because everyone is reluctant to stop. So again, going to the IVF Worldwide website, looking at this box with over 50,000 cycles of data, this is what we all do in our practice. Only 12% will advise stopping luteal phase support when the HCG is first positive. 22% will continue until the fetal heart is seen with an ultrasound at 6.5 to 7 weeks, and I guess I fit in this group most of the time. But 2/3 of clinicians, 2/3 of clinics are carrying on luteal phase support with progesterone way beyond the time at which the placenta becomes active, and really way beyond the time at which it's necessary. But I'm not critical of that practice because everyone who does this knows that IVF medicine is not only about science, it's about psychology. And I think if the woman is more comfortable continuing with progesterone, perhaps in a reduced dose, up to 10 or 12 weeks, I don't see it does any harm. I don't see it as a drawback. But if she's more comfortable stopping when science suggests things are okay, probably stopping at the time of the first ultrasound or even earlier has an equal chance of a healthy baby. And then to talk a little bit about whether progesterone is necessary in frozen embryo transfer cycles. Well, there are a number of approaches if you wish to do a frozen embryo transfer cycle. If the woman has a good regular menstrual cycle with good ovulation, and we would track a cycle using ultrasound and measurement of steroids and gonadotrophins to see the increase in estrogen, to see follicle development, to see endometrial development and thickness, see the LH surge and look at luteal progesterone. If she's a regularly menstruating woman with good ovulation, there's no reason not to use a natural cycle. In some clinics, the definition of natural cycle includes using an HCG trigger and possible luteal phase support. Personally, I don't find that natural. That's not what my mom did when she made me, or my grandma when she made my mom. Natural cycle means no drugs. So the word modified natural cycle has been used. For the women who don't ovulate well, or maybe for those who've had 1 or 2 transfers without success, in our own practice, the second approach is to use low-dose FSH, usually recombinant FSH with tracking, again, look at endometrial thickness as well as follicle development, and give an HCG trigger. And in that stimulated cycle, we would give luteal phase support, either with HCG or progesterone. And then, of course, the third approach, which is particularly useful for cases who don't ovulate well, maybe women with polycystic ovary syndrome, anyone who's close to menopause or postmenopausal needing an embryo transfer, will require some form of estrogen and then progestogen luteal phase. If you're using the natural cycle, and this is my preference, it doesn't seem necessary to give progesterone luteal support in what would otherwise be a natural cycle. And here's a couple of studies to validate this. This was a randomized trial giving progesterone or no progesterone in a natural cycle. They did occasionally do an HCG trigger, and this was intramuscular progesterone using cleavage stage embryos. And again, the important feature is to have screened the cycle before you do the transfer to make sure that the quality of the ovulation in the cycle is good. And you can see no difference between the two groups, whether or not progesterone was used. And another study again, this time using, again, day 3 embryos with micronized progesterone, whether or not you gave progesterone in a natural cycle didn't seem to help. And I don't find that surprising, because if you make a good follicle, a good LH surge, the natural secretion of progesterone should be enough to sustain a pregnancy, as it is in all the natural pregnancies that we see in our obstetric practices. And this was an attempt by Nick Macklin's group in Holland to do a randomized study with big numbers, looking at the relevance of modified versus artificial cycles for frozen embryo transfers. So moving on to the use of artificial cycle, and I'll show you how that worked. What they thought of as a modified natural was looking at ultrasound growth of the follicle, giving an HCG trigger when the follicle was more than 16 millimeters. But interestingly, they didn't look at endocrinology of the natural cycle, and they didn't set a minimum value for the endometrial thickness. In our practice, we would look at 8 millimeters usually as the minimum, hoping that it may be cancelling a cycle in a natural cycle if we didn't achieve that. And this was randomized against an artificial cycle, which is pretty standard, with 6 milligrams a day of estradiol valerate, increasing to 8 milligrams if the endometrial thickness was not good, using monitoring with ultrasound to look at thickness, and then when it reached 8 or more millimeters, giving utrogestan for luteal phase support. The strength of this study was in its numbers. They managed to randomize over 1,000 patients, with almost 1,000 being available for analysis, randomizing about 495 to the natural cycle and 464 to the artificial cycle. So an impressively large study. The amount of work that went into this was impressive. And these were the outcomes. 959 randomized. These were all regularly ovulating women of good age, natural versus artificial frozen embryo transfer. Again, not quite in keeping with modern practice. This was published in 2016. These were day 3 embryos that were slow frozen. We would now look at vitrified blastocysts. I guess the big drawback of the study was the pregnancy rates were not impressive in either arm, although clearly there was not inferiority of the natural cycle compared with the artificial cycle, whether you look at live birth rate or clinical pregnancy rate. Artificial cycles were cancelled more often because of low endometrial thickness, but that wasn't a criteria for cancellation in the natural cycle. But I don't think there's any evidence that taking regularly ovulating women through these programs of estrogen and progestogen is helpful in the first 1 or 2 transfer cycles. But clearly, if things are not working well and you've had a couple of failed transfers of good embryos, trying something different is often a good idea, and either a stimulated cycle with FSH or an artificial cycle with estrogen and progestogen is not a bad second-line treatment. And then looking again at oral versus intramuscular progesterone for frozen embryo transfer. This is Bruce Shapiro's study from the US. It was a retrospective study, non-randomized, using various formulations of estrogen, but all of them having IM progesterone. And again, in the US, they like giving medications for many weeks, so they had estrogen progesterone until 10 weeks of pregnancy. And you can see comparable live birth rates of 49 versus 49%, whether they had vaginal progesterone or crinone or intramuscular progesterone. So if you're going to use a luteal phase support in a frozen embryo transfer cycle with estrogen, your choice of intramuscular or vaginal is up to you and the patient. But personally, I think the intramuscular drawbacks outweigh the benefits. So really, to summarize what I've said to you in the talk, luteal phase support is clearly necessary for cycles of IVF with or without ICSI with a fresh embryo transfer. HCG 3 injections might be preferable to vaginal progesterone to some patients, but it's not a good idea to use it if there's any realistic risk of an OHSS. We would always keep use of HCG only to poor responders with a low AMH, maybe older patients who hadn't over-responded to stimulation. I haven't had time to show the evidence this evening, but we do not give luteal phase support to our simple IUI cycles, whether stimulated with clomiphene or letrozole or low-dose FSH, because again, the follicular development is pretty normal. They have good ovulation with an HCG trigger, and the corpus luteum will work well. So we don't find it necessary in most cases to give luteal phase support. We do often measure progesterone in the mid-luteal phase, and of course, if it is lower than it should be, you can give luteal phase support in another cycle. Medicated frozen embryo transfers, whether they're stimulated or estrogen gestogen, obviously require luteal phase support, but natural frozen embryo cycles do not. I like doing natural cycles. The baby being conceived in a healthy environment with no medication is something that many of our patients prefer, and our pregnancy rates, as in the randomized trials, are equivalent to those that we see with stimulation. I've been quite critical of intramuscular progesterone. I don't think it's indicated for most patients, but may be necessary for some. And the evidence is good for micronized progesterone, both in terms of safety and effectiveness. Thank you very much for listening, and I'd be happy to take questions. Thank you.
Thank you, Dr. William Laser, for your wonderful talk, where you have covered all the fresh cycle and the FET cycle. But I would like to know one thing from you. Will you like to give to in FET cycle single progesterone support, or you want to add some more? Even if we want to do give to these patients up to the cardiac activity once it comes.
As I said in my talk, my own preference is to try and keep things fairly simple. So FET cycle, vaginal progesterone, I think because many of our patients are full-time working women, so twice a day is much better than 3 times a day. Then they don't have to take the progesterone pessaries to work. So a preparation that gives you 400 milligrams BD is preferable to something that is TDS. And for natural frozen embryo transfers or stimulated with FSH, I think that's sufficient. We wouldn't add in HCG as well. We try to keep the FET process as simple as we can, and we get very acceptable pregnancy rates with that. But always, when you're looking at these meta-analyses of data from randomized trials, look at the number of patients who are excluded, because all of the trialists exclude many, many patients that we have to try and look after in practice. And in the real world that you and I work in, every patient is different, and you have to come up with an individualized protocol that is in keeping with her needs. Frequently, they'll have had many previous cycles in other clinics or in our own practice. And the randomized trials don't tell you what to do with those patients. They all recruit first cycle, beautiful young women doing their first cycle IVF. I wish I had more of them in my practice. I'm seeing the older ladies who've done it 6 times already and are very, very desperate. And so in that circumstance, I agree with you. It's perfectly reasonable to use progesterone plus or minus HCG in different doses and formulations, because it's not always easy to know what's best in those very difficult patients.
Thank you.